Well, thank you all for joining today, and thanks very much for the invitation to speak to this group. So I'm going to talk about frailty and low physical function in people with early stage and advanced cancers, and focus mostly on gynecological cancers for this particular group. Oh, I've got too many screens going. Got it there. I can advance the slides properly now. So in terms of today, just a bit of a background around physical function and exercise and rehabilitation in cancer generally. Then talk about why frailty and reduced physical function may be important for people with gynecological cancer. And then really highlight the Be Balanced project, which is a project that is involving this group and actually came out of one of these meetings that we had previously. And then just really talking briefly about some recent work looking at higher risk groups like advanced cancer, and finish with some local resources for anyone that's interested in this area for what's happening locally. So is low physical function even a problem? Often when I'm looking at the role of exercise or rehabilitation for people with cancer, everyone sort of assumes, well, yes, during treatment and after surgery, people tend to have reduced function and fatigue and some symptoms, but they typically bounce back after their treatment. And so I like to respond with this data from the NHANES project in the US. So this is population-based level data in which they have asked individuals to self-report difficulties with particular activities. And so here in a physical therapy, we talk about participation. So that's kind of doing the things you need to do during your day, and then performance limitations, being able to do specific tasks. So here what I'd like to highlight is that for those individuals that do not have a cancer history, they're in the lighter blue color. Then individuals who've had a prior cancer diagnosis within the last 5 years are in the kind of darker blue. And those that have a cancer diagnosis more than 5 years are in the gray color there. And so what we see here is that a vast number of people with a cancer diagnosis report a participation restriction. An example of that is difficulty with chores, up to 25%. Over 50% report some issue with physical performance limitation. And that's an example of that is over 20% difficulty walking a quarter mile. This is US data, so they use miles, or difficulty standing from an armless chair. What I like to highlight here is that really there's no difference from the time of your cancer diagnosis. That really doesn't play an important role. People after a cancer diagnosis are having limitations, and that doesn't improve over time. So our argument is that then rehabilitation services and exercise promotion are needed because they could address many of these side effects. So I just want to highlight here that the first exercise guidelines for people after a cancer diagnosis were published in 2010, and they were the first attempt to give some guidance. First and foremost, avoid inactivity, return to daily activities as soon as possible after surgery, continue with normal activities and exercise as much as possible during and after non-surgical treatments. And then the physical activity recommendations were the same as the age-appropriate guidelines for Americans, which at that point was 150 minutes per week of moderate intensity aerobic activity, 2 days a week of strength training for major muscle groups, and daily stretching. These guidelines were actually updated in 2019. I had the opportunity to co-lead that with my colleague, Carrie Winter-Stone at Oregon Health Sciences University. And what we were able to do in these guidelines is go beyond what the original guidelines had and talk about symptom management. So if we're worried about physical function or fatigue, is there an exercise prescription that's more targeted for that group? So the main findings in a snapshot of the paper is we still agreed with the original 2010 guidelines. So those are here: avoid inactivity, and overall for improving general health, aim for those exercise guidelines for adults in the general population. But what is new with these guidelines that came out in 2019 is that for people during and following cancer treatment, research shows that a lower amount of exercise can help with the following cancer-related treatment syndromes. So if a person presents to you with cancer-related fatigue, or impacts on their quality of life, or reduction in physical function, anxiety, or depression, we found that more like 3 times a week of 30 minutes of activity. So if you want to do the math, that's 90 minutes of activity versus 150, should start to show a benefit on those symptoms that the person's reporting. We also found that, say, resistance training on its own could be beneficial. And we tried to color code things. So the goal with this infographic was that resistance training 2 days a week on its own should help with cancer-related fatigue, health-related quality of life, the purple physical function, and also lymphedema and bone health. Or aerobic activity alone has some benefits, or the combination. So really trying to give people more of a prescription to address what symptoms they're impacted with. So the last piece I'll just highlight here is that in combination with those 2019 guidelines, there also was a paper from our group trying to translate that information for a clinical audience. And so this was in CA Cancer Journal for Clinicians, and fundamentally asks people who are part of the cancer care continuum, oncologists, nurses, other supportive care team members, to ask, advise, and refer. Ask people about their activity levels, provide information the guidelines existed, and refer people to any resources or programs that did exist in the community. So I'd like to harken back to our data that we had about physical function from the 1992 to 2002 NHANES, which I previously showed you. And if this was a class, I could ask you all to put up your hands, but I won't need you to do that. Has anything improved in 16 years? So we were able to look at reanalyzing NHANES data in the newer cycle, so the 2015-2018 cycle, basically repeating the same analysis. So, do you think anything's improved since the time we've had these exercise guidelines, since 2010? And the answer is no. So I've added here that actually the system here, the main snapshot here is that it's actually worse across the board. Whether you've had a cancer diagnosis or not, more people are reporting performance limitations. The yellow bars are the additional number of percent reporting those issues. Difficulty walking a quarter mile, worse for all groups, but maybe worse for those individuals with a prior cancer diagnosis. So we're doing more poorly. And difficulty standing from an armless chair, again, worse for all people who were part of the NHANES study, but potentially a little bit worse for those that had a previous cancer diagnosis. And the time of diagnosis, really hasn't improved things either. So just a bit of background to where physical function is. It's a problem in individuals with cancer generally. And so interventions that exist aren't really reaching the groups that maybe potentially need this service. So gynecological cancer now, why are we talking about this here today in these rounds? So as I mentioned, some of the work that we've started to do here at UBC came from one of these rounds and having a conversation with both Jillian Hanley and Anna Tinker. And so this was the data that was reported on that day, where Jillian talked about some of the causes of death for those individuals with epithelial ovarian cancer. And what it was found is that while ovarian cancer patients continue to die primarily from the ovarian cancer, what they found in long-term ovarian cancer survivors, they're particularly vulnerable to falls and deaths from falls. And it was 5 times higher than those that than the general population, and an age match cohort. Also of interest, and this is unpublished data from Jillian, I think. I didn't have a chance to consult her, but we've been working on a grant, so this information was there. Also, that the falls risk was 50% higher within that first year of individuals who had undergone surgery for ovarian cancer compared to other gynecological surgeries that weren't cancer related. And so this suggests a really much higher rate of falls. So that kind of started us down the road of there's problems with physical function, there's an increased risk of falls. Is there something we can do to address this? So this is just a little bit about falls and cancer. Like, why would individuals after a cancer diagnosis potentially be at a higher risk for falls? And this is a really nice review published in Clinical Oncology in 2010 that kind of goes through all the information if you're interested. What I'd like to highlight here is that aging is the primary risk for falls. So as we age, our risk of a fall does increase. But there also is this overlapping element of an effect of cancer treatment above and beyond that. And so some of the suggestion here is that peripheral neuropathy related to some of the chemotherapy agents that are provided potentially can be problematic. So neuropathy to the feet, problems with balance could impact that. Overall general fatigue. So someone is feeling fatigued, have the reduction in physical function. they may be just at a higher risk for falls, as well as cancer-related cognitive changes, which we've been doing some work on as well. A general just not feeling as sharp, that cognition and falls are very tightly linked as well. And then muscle strength and function. If people have reduced strength, weakness, physical function, power, all these things, and balance, all these things are linked to an increased fall risk as well. And these are all potential side effects of cancer treatment. So narrowing in on the muscle strength and physical function elements, there's a lot of interest in this now in the cancer space. And so what's been generally found is that reductions in muscle strength and poor physical function are now linked to poor survival after a cancer diagnosis. And there's a lot of interest in this term of sarcopenia. I was just at a meeting for the last 3 days, an international frailty and sarcopenia meeting. So I've spent immersed in this over the last couple of days. But, age-related loss of muscle mass, a reduction in quality of that muscle and muscle strength is normal with aging. That is a reality that we all have to face. But sarcopenia is a syndrome where it's characterized by a progressive and generalized loss of skeletal muscle mass and strength that with an increased risk of adverse outcomes such as disability, poor quality of life, and death. So it's kind of an accelerated aging, for lack of a better term. In the cancer space, there's been a lot of focus on this because about a third of people or more individuals may be sarcopenic at diagnosis. So already they're at risk of some of these outcomes around physical disability, poor quality of life, and death. And then they become more sarcopenic with the cancer treatments due to fatigue, lower physical activity levels, some of the impact on the drugs on the muscles themselves. So a lot of concern that this is something that maybe needs to be more attention needs to be paid to. So what people have done is started looking at how do we measure sarcopenia. And where the cancer space has really focused on is the fact that cancer patients actually have CT scans routinely as part of their cancer care. So that's kind of a unique element to being able to merge the worlds of sarcopenia and oncology, because other disease groups may not have CTs available. And so that's why this has been really leveraged in the cancer space. Typically what's been done, and there's a lot of evolution and innovations coming, but typically the L3 slice of a CT scan, which is typically available for people with colon cancer, gynecological cancers, they are having CTs in that area. Body composition at the level of that single slice is correlated with whole body composition. And a lot of work was done to pick the best slice, and this has been identified as the best slice to be a proxy for overall body composition. And so what people do, this is a picture of that slice with an overlay of a body composition information. And so anything in blue is subcutaneous fat, anything in red is skeletal muscle, anything in yellow is visceral fat. You can see bone there on the vertebrae. This is not an anatomy lesson. I don't know if my pointer shows up for you on your screen as much as it does on mine, but the vertebrae is that kind of butterfly looking thing kind of at the bottom of the slide. So you're orienting from back to front. Oh, sorry, there, my computer screen goes to sleep randomly. And what people do then is they take that information to quantify muscle quantity using skeletal muscle index. So it takes all this red here, normalizes it for height to come up with the metric of muscle quality. Muscle quantity. Muscle quality is the attenuation of the muscle. So what I'd like to highlight here in the back extensor muscles here. So if you look at your vertebrae, those big red circles on each side, you'll see they're kind of infiltrated by green, and that's intermuscular fat. And that typically develops due to kind of poor muscle quality. The contractile properties aren't as good. It's just kind of infiltrating the muscle tissue. And so what that ends up doing is kind of decreasing the kind of grayscale, which is the original CT scan of the muscle itself. So it's kind of lesser quality muscle. And so that's typically measured in Hounsfeld units. So people are applying this to looking at survival endpoints and disability endpoints. So here I just wanted to highlight the most recent systematic review that has used this sarcopenia approach and muscle attenuation approach to look at survival in epithelial ovarian cancers. So this was a systematic review and meta-analysis, and it included over 1,200 patients. And what they did is they had CT scan information that they were able to characterize skeletal muscle index as well as muscle attenuation. So this is what they found. Overall, 2 studies reported that patients who are sarcopenic have reduced overall survival. And of the 6 included, 4 actually reported no association with survival. So there's still a lot of kind of nuance around this and a lot of more that needs to kind of be explored. But what they saw was skeletal muscle index. So this is muscle quantity. There are 4 studies that reported this. And what they show, if we look at our forest plot, is that this is the odds ratio on 5-year survival for those that are deemed sarcopenic using a skeletal muscle index cut point versus not. And what you can see is it favors non-sarcopenic. So those individuals who were not sarcopenic had better 5-year survival. You can see from those who are used to looking at these things, we got our median in the blue, we got our confidence intervals on each side. And when they cross the 1, it's sort of equivocal. And the big diamond is our summary of all that research put together. And so there is a suggestion here, although it's very close to that, touching that 1 line there, that those who are not sarcopenic have better survival at 5 years. What we see with muscle attenuation, you can see there's only 3 studies now that had reported on this. Similar sort of things suggesting that those that have higher muscle attenuation, and that is better quality muscle, have improved 5-year survival compared to those that have the lower muscle attenuation using identified cut points. So a lot of interest in understanding if there's ways to address this and improve survival for people after a cancer diagnosis. So that gets us to exercise. And that's the reason that most of the work that I do is focused on how do we use exercise to address symptoms and side effects of cancer treatments. So could exercise be an effective intervention to reduce the prevalence of this frailty or sarcopenia endpoint, and potentially, when we zoomed out to our ovarian cancer data from Jillian's group, to reduce falls? And this is going back to that sort of why people fall after a cancer diagnosis. You can see it's many of the things we talked about. And so if people are inactive, they become deconditioned, they have muscle weakness, that increases their risk of fall. So can we intervene on this inactivity and physical deconditioning to reduce the risk of falls? Now, the research on exercise generally to reduce the risk of falls in general is, there is some solid evidence for that in the general population. There's much less in people living with and beyond cancers. This is a very recent Cochrane review that tried to look at all the data available for whether exercise reduces the risk of falls in people living with and beyond cancer. There are 11 studies that were eligible to be included that had about 800 people, and it compared exercise to usual care. The quality of the evidence, unfortunately, was very low for primary outcome rates of falls. And it was even worse when falls were a secondary outcome. And so overall, they found that there's a paucity of evidence for exercise training to reduce falls rates in people living with and beyond cancer. Exercise may improve strength, flexibility, and balance for people in this population, but the evidence is of very low quality. So I think it shouldn't dissuade us. This should make us want to do more of this work to improve the quality of the evidence available and hopefully inform more information around whether exercise can play a role in reducing risk of falls in people living with and beyond cancer. So that's where B-Balance comes in. This is a sort of pilot feasibility study that was funded by the Women's Health Research Institute. And it's targeted physical activity to improve mobility and falls risk in women living with ovarian cancer. For those that are interested in having fall as a primary outcome in any trial, that is a large N that would be required. So we went with kind of falls risk. So understanding kind of maybe what the pattern was like and not necessarily falls themselves. So this is a really new group that came together around this project. So for those that are come to these meetings often, you'll see Jillian Handley there on the second in the second row on the, I guess, left-hand side for you, as well as Anna Tinker, top right, who are very much involved in gynecological cancer research. We also brought out in new team members. So top left is Dawn Mackey from SFU, who is really focused on geriatrics and falls. In bottom left, we have Linda Trin, who's a physical activity and behavior change specialist, looking at cancer survivorship specifically from the University of Toronto. And bottom right is Iris Lesser, who's a junior investigator on exercise and cancer survivorship based at the University of the Fraser Valley. So we wanted to bring her into the fold to some of the work we've been doing as well to kind of grow our capacity around the Lower Mainland to do some of this work. So the objectives of this project is to measure the feasibility of delivering the B-Balance program from a virtual live video setting. Secondary objective, to evaluate the preliminary efficacy of the B-Balance program. So does it improve physical function, quality of life, aerobic capacity, strength, all those things, as well as we included a falls diary and healthcare utilization survey. And our last objective is to explore patient satisfaction. What do people think of this project? Ultimately, we determined a virtual live video setting was the way to go, rather than say an in-person class. That's for two reasons. One, with COVID restrictions, in-person exercise was very much curtailed. And two, even prior to COVID and all the discussions we were having around intervening in this group, ovarian cancer has a lower prevalence than some other cancer groups we've worked with in the past, like breast cancer. And so getting a group of people together who had had this diagnosis, who were interested in an exercise program, potentially was challenging. And so we thought a virtual based program would allow people to join from around the province and really increase the potential uptake of the program and test whether that's something that could be done then across the country going forward. In terms of who is recruited to the study, we're looking for women aged 40 to 75 years, completed primary chemotherapy treatment, are within 1 year of completion of that primary chemotherapy without known recurrence, really trying to get people in that 1 year after diagnosis when really we feel intervention may be really important based on Jillian's findings around falls risk. They have to have access to a smartphone, tablet, laptop, or desktop computer with a camera and microphone and internet connection to be able to participate in the class. Speak English to ensure safety in the delivery of the physical activity intervention, especially virtually. If someone's having a challenge, we need to be able to communicate with them effectively very quickly. In terms of exclusion, we do have some pre-exercise safety screening questionnaires. So if someone does not pass that, they cannot enroll in the program. They have to consent to be adhering to our safety requirements, which basically being seen on video for the duration of the class. That's how we monitor safety. And so we have an emergency action program protocol in place related to being able to see people on the screen. So we need them to be able to be seen. And if someone's experienced 2 or more falls in the prior 6 months, that individual might be at a higher risk for falls that a virtual physical activity program may be appropriate for, and they might be more appropriate for a referral to a falls clinic and have more focused follow-up for that. So what are we asking people to do? They're eligible, they're coming into our study. There's 3 in-person assessments, one done at baseline, midpoint of the intervention, so at week 6, and then end of program, week 12. At that, we do in-person anthropometrics, height, weight, waist and hip circumference, as well as physical function measures. And then we have 2 sessions per week that are 60 minutes in duration for 12 weeks, so 24 group-based virtual exercise sessions. And we also ask people to do 1 session a week on their own of the same program. Over the 12 weeks, there are 2 virtual nutrition sessions where individuals can go to a group session with a registered dietitian, and we cover sort of main healthy eating information, and there's some homework to do and a little bit of barriers and things to work through in the second session. What people receive to being part of the intervention is they get our B-Balance manual. So this is outlines how to join Zoom. We've become very good at troubleshooting Zoom issues. Exercise sessions, so what the progressions are, what the exercises look like, as well as behavior change homework. So a lot of goal setting, working through barriers, those sort of things. They also receive 3 resistance bands in the mail. The intervention is very much a circuit-based class, focusing on resistance training and mobility and really sort of functional movement, with the resistance bands as our main way to make things harder and really stimulate change over time. The class format, it's 60 minutes long for the class, but you can see here we open the class up 15 minutes prior, and that allows social time. What we recognized from in-person classes is and in-person exercise projects we've done previously is that as much as we thought they really wanted to come and do exercise in person with us, it was more they wanted to talk to their friend that also came at the same time to the gym and chat to them, and exercise was like, oh, I can do this at the same time as I get to meet up with my friends again. So we wanted to try and mimic that in the virtual setting as well. And so this just is opened up free time. And after people meet each other in the first couple of classes, there's lots of chatting and a lot of the sharing of information and things that happen in person. So we're really happy that this kind of has worked well in the virtual setting as well. Then the first 15 minutes of the class is kind of educational, kind of how are people doing after the last class. We worked a lot on insert X. Do people have any problems, questions, concerns? And then the main part of the exercise intervention goes from that 15 to kind of 70-minute time point where it is the fitness class, has warm up, exercise, stretch, and cool down, and then a little bit of a wrap up, 5 minutes, you know, how did it go? We report our rating of perceived exertion and those type of things. So virtual exercise was new to us. Right around the time of the pandemic, we were already starting to think about this. And then obviously the pandemic just pushed us forward to that. This is just a screen grab of one of our exercise instructors, Sam Meyer, who's a doctoral student in my group, leading a home exercise class from her very nicely. This isn't even a Zoom background, that's her real house, leading the exercise class. So this is just a snapshot of sort of what the structure looks like in terms of how we progress people, what information the instructor has. So you can see here, week 1, the education focus is fall safety during exercise. We talk a lot about having nothing, you know, your space is free of clutter, you don't have rugs, things like that that might be a problem. Then we start with an 18-minute circuit, some balance exercises, some core. We do a little bit of flexibility, and there's a rating of perceived exertion score, a goal of 10 to 12, which is kind of light to moderate. As we work through the weeks, you can see each week has its own kind of educational focus. So both classes that week talk about that. So week 2, benefits of exercise for cancer symptoms and health. Still an 18-minute circuit, very similar. Week 3, we now have a slightly higher rating of perceived exertion goal. So now it's 11 to 13. So as people get more comfortable with exercise, we ask them to push a little bit harder. And then we add the nutrition session in week 3. The home exercise, which is the far right column, you can see here, we don't add that in until about week 4 or 5, once people are kind of in the group, understand the exercises and how to do it. So how have things gone to date? We're aiming to have 30 people, so we're on our way. We've had 25 referrals. 21 are from oncologists and 4 were self-referrals. 2 people are awaiting screening of that group, and 2 we have not been able to contact. We screened 21, and in terms of eligibility, 4 have been ineligible. 1 due to language barrier, 2 due to class timing. So we try and find times that we know work best for most people, but inevitably there's always one person that, you know, needs a class at 9 p.m. or 6 o'clock in the morning and no one else wants that time. So we are challenged by that. And 1 individual had been kind of too far past end of treatment to be part of our eligibility criteria. 4 were not interested. 1 thought the technology and the Zoom and everything was just too much. They were not going to engage. 1 didn't have the time to commit. 1 just wasn't interested, and 1 was too active. So really it was doing a lot of activity already and felt like what we were offering was sort of already being covered. 3 people are eligible, but they're on the wait list. So they are in this gray zone where they're waiting for the next session to start. So of the 10 who are eligible, everyone completed baseline testing. 5 people have completed the intervention. 5 are currently in the intervention right now. It finishes next week or the week after. We had 1 person withdraw early on, no reason provided. And so 9 people have completed the midpoint assessment. 4 people have completed the 12-week assessment. And we have 5 people here on the one side who are currently in the intervention, and they'll be completing their 12-week assessment in the next couple of weeks. So our main observations to date. One is that the majority of the referrals have come through the oncologist versus self-referral. And this is a bit different than our breast cancer study, which we're also running right now, which is virtual exercise. It's almost like a 50-50 split of oncologist referral and self-referral. So a bit of a different pattern for this group. We're just learning how to best engage this group. Participants have had a varied fitness level and experiences with exercise, from very deconditioned, completely new to exercise, to some who are quite active, but looking for some of that structure and some of the social component to really kind of keep them engaged. We've had really good adherence to the exercise intensity, so reporting those rating of perceived exertions, regardless of fitness level. And that's the real challenge and art and science of the instructor, is making sure everyone's challenged appropriately within the class. And we have a lot of experience now kind of tailoring the class for each person, what works for them, and what, you use the red band, you're using the yellow band, it's all good, we're all doing the same activity. I think we're finding good interest with the program, but inevitably finding a time that works for everyone over 12 weeks is a challenge. And so we've run morning classes, we've run afternoon classes, we've run evening classes, and inevitably sometimes the 1 o'clock is the one that everyone wants one session, and then the next session everyone wants the morning. And so it's a little bit of juggling. And I think going forward, we would just hope that we could have multiple sessions that people can attend. The other thing we've been finding is that the social connection is happening. That first 15 minutes of social time is happening. The classes are chatty. All the things we hope to happen are happening. People are exchanging their contact information themselves. There's potlucks happening in some of our other virtual classes. So all sorts of things people are connecting, which I think is an important part of this. The nutrition education sessions are really popular, and people have been asking really great questions. There's been a lot of requests for a video of the homework. So could we film the class and have people they'll just follow it like an exercise video. So we've done that. And we also have a video once you've graduated from the class, you get the videos to keep going with over time. For our third aim, it is patient satisfaction. We ask on a questionnaire, but we're also doing interviews with people to get a little bit more understanding of what worked about the class, what didn't, what did you like best, what could be improved, so we can refine this going forward. So that's B balance. In the last little bit here, I just want to talk a little bit about advanced cancer, because I think this is a group where frailty, sarcopenia, lower physical function may be even more of a challenge, but also integrating exercise is also challenging for all the same reasons. And so we've been doing a lot of work over the last 2 to 3 years with an international working group on trying to address exercise specifically in the advanced cancer setting. And so, it's no surprise probably to many in this group who worked in this field that with advanced cancer, the sequential cancer treatments, so people are sort of receiving treatments on and off again for many years, have a high symptom burden. But when you talk to people with advanced cancer, maintenance of functional independence and management of those symptoms are really a top priority reported by people with advanced cancer. And so exercise has a potential to facilitate improvements in functional independence and manage symptom management, but it hasn't been used as much in this group. And one of the main reasons is that with advanced cancer, one potential issue with advanced cancer for some individuals is it has metastasized to the bone. And so bone metastases really complicate an exercise prescription and physical activity promotion on all fronts. People with bone metastases don't know what's safe to do. The oncology care team also don't know what to advise. The exercise professionals don't have the information the oncology team has. So there's a real gap in terms of information sharing and being able to address this effectively. And the healthcare providers and exercise professionals do have concerns about potential skeletal complications. No one wants to cause a fracture, a spinal cord compression fracture, a fracture of the pelvis or long bone. And there's a lot of uncertainty around what is the right risk management approach, like how do we screen people effectively so that we can reduce the risk of any skeletal complication. So we brought together a group of exercise professionals, allied health professionals, oncology nurses to try and work on this. And it was called the International Bone Metastases Exercise Working Group. It was co-led by myself as well as Sarah Weller, who is now at BC Cancer, and Jen Goulard, oncologist based at BC Cancer Victoria. And so throughout a process that involved a Delphi, a systematic review, an in-person meeting, and guideline generation, this was the overarching recommendation that the group put forward, that regular exercise has the potential to maintain or improve physical function and health-related quality of life in people with bone metastases, and the perceived risk of skeletal complications should be weighed against the potential health benefits. So really suggesting this is underutilized and we need to find a way to ensure that there's greater opportunity to provide physical activity programming for people with advanced cancer. We have 5 main recommendations. I'm just highlighting number 2 here. Really, that consultation with the medical team is strongly encouraged before an exercise professional provides structured exercise for a person with bone metastases. And this is to obtain key medical information and establish bi-directional communication for initial assessment and exercise training throughout care. A main challenge is that the individual who's an exercise professional has difficulty oftentimes getting the information about what's going on for this person. And so this is just a schema of how we might do a history for pre-exercise screening. And it has cancer-related factors, lesion-related factors, and person-related factors, which are outlined here. And so the care team holds this information, but don't know how it applies to exercise. The exercise professional wants to know this information, but typically doesn't work within the cancer center, so doesn't have access to the electronic medical records. So our next step is we've suggested this conversation needs to happen, and the next work we're working on now is some KT funding opportunities to try and develop kind of prescription pads or materials that these 2 groups can use to talk to each other, as well as the patients themselves to be educated advocates and know what to ask their oncology provider or exercise professionals they're working with in the community. So just to leave you with this slide here, this is a one-stop shop website that we've been working on to have everything to do with exercise and cancer here in British Columbia in one place. So it's cancerexercise.ca. You can see there's drop-down menus for if you are a person with cancer, a healthcare professional, an exercise professional. There is all the things we've been doing with BC Cancer, with prescription pads for the physicians, fact sheets, videos. It's all linked through hopefully this one page that will send people to a variety of different places, as well as what research studies are going underway, what community-based programs there are available throughout British Columbia. So if you are interested in this, hopefully you'll find this website useful. And if there's something missing, please do let us know. So in summary, reduced physical function and sarcopenia are prevalent before and after a cancer diagnosis. There's increasing interest on the impact of physical function, frailty, sarcopenia on falls risk, morbidity, mortality, specifically in the cancer space. Exercise may be one intervention to address reductions in physical function, muscle strength, sarcopenia, function balance, but a lot more research needs to be done on how exercise can manage many of these impairments, and also how do we deliver this at scale. We know exercise is a benefit. We know people could benefit from it, but it is a challenge to figure out ways to deliver this programming that's safe and effective and can reach people across the province or wherever they are. So with that, I'll stop there and see if there's any questions.